Good afternoon. Welcome to this final Friday verbal session of the conference. You are in the room Sunflower for the session on wastewater monitoring. Our first presenter of the session is Hemali from Emory University.
Hello. So thank you everyone for joining on this last day of the conference. My name is Hemali and I'm a postdoc at Emory University. So today I'll be talking about respiratory disease surveillance and circulation patterns at a more local metropolitan scale in the greater Atlanta area. So I want to thank Stephen Hilton at Emory University for his contribution to this work, and of course Dr. Boehm at Stanford University and Dr. Wolf from Emory University, who have led this tremendous work in wastewater surveillance and are also senior authors on what I'm sharing with you. So especially since the COVID-19 pandemic, it's not surprising that acute respiratory illnesses, or ARI, is one of the leading contributors to the burden of infectious disease in the United States. And it's associated with millions of illnesses and hundreds of thousands of hospitalizations every year. In 2022 and 2023, the season was characterized as a triple-demic with surges in SARS-CoV-2, influenza, and RSV rates. And nearly 40% of US households reported infections by at least one of the three viruses. And this simultaneous circulation put a substantial strain on healthcare facilities. And these endemics describe synergistically interacting epidemics that occur in contexts that have shared drivers of disease burden that exacerbate individual impacts. So understanding the epidemiology and potential co-occurrence of ARIs at a local level where there are clear shared drivers of health could better inform public health response and capacity building. So traditional clinical data relies on healthcare access and healthcare seeking behavior, which typically happens in more severe cases. And in comparison, wastewater surveillance encompasses individuals regardless of their access to healthcare services or testing, and ensures inclusion of less severe or asymptomatic cases. So those connected to municipal sanitation and sewer systems are included in wastewater surveillance, improving the representation and robustness of infectious disease monitoring data. And this works because when a person has an infectious disease, they often shed that pathogen in bodily secretions. So bodily excretions from people within a sewer shed goes down the toilet, the sink, and other drains, and ends up in the wastewater plant, where we can collect samples. So this composite biological sample can provide information about the whole community with a single sample, and that promotes health equity by inclusion of these potentially underserved groups. It also provides community insights when clinical data might be slow, incomplete, and unavailable. And there are several studies that have established the relationship and correlation between target viral RNA detection in wastewater samples and the number of clinical cases in that area. So using this infectious disease surveillance methods and data, we were interested in understanding disease circulation in the greater Atlanta area by investigating the local co-occurrence and variation of 5 respiratory diseases. Specifically, we tracked SARS-CoV-2, RSV, influenza A, influenza B, and HMPV. And we did this across 7 sewer sheds. So our data was collected at 7 publicly owned treatment works, or POTWs. And these POTWs were dispersed across the greater Atlanta area. So moving on to methods a little bit. So as I mentioned, the composite settled solid samples, say that a bunch of times fast, were collected multiple times a week from the 7 POTWs. And this was done over 2 respiratory disease seasons. So for the first season, we had a little less data available. We sampled from these 4 sewer sheds displayed here from June 26, 2022 to July 29th of 2023 for SARS-CoV-2, RSV, and influenza A. And then we sampled across all 7 of the POTWs that are in our wastewater scan program from July 30th, 2023 to April 20th, 2024 for the 5 respiratory infections, SARS-CoV-2, RSV, influenza A and B, HMPV. After the samples were collected, RNA extraction and digital droplet PCR assays were performed to obtain PMMOV normalized viral RNA concentrations of the 5 targets per POTW site. And I am happy to share resources that detail these methods a little bit more in depth if anyone is interested. We then characterized the season for these 5 targets based on viral RNA levels. We calculated onset, which was the first day when all samples, so looking at non-normalized data, so when all samples of a 14 sample look back period had concentrations that were higher than 2,000 copies per gram of dry weight. Offset was identified as the first day after an onset event, where only 7 samples during a 14 sample look back period had concentrations over 2,000 copies per gram of dry weight. And then co-occurrence, which was identified as simultaneous onset of more than 1 target. And then the peaks per onset period were also identified. And then lastly, we calculated Kendall's tau correlation coefficients to compare disease circulation among viruses and POTWs. So now looking at the results, so we start off with the normalized RNA concentrations of each target over time in the lighter shade, and it's plotted with the state of Georgia aggregated weekly positivity rates, so the clinical data in the darker shade. So just a quick note that the scales of both the right and the left axis vary a little bit by the targets. So SARS-CoV-2 tended to have cyclical waves of higher circulation every few months. Clinical data, or the data show that influenza A and RSV generally peaked during the winter months, so around November to January, whereas HMPV and influenza B tended to peak later in the season, January to around March. So here are the Kendall tau correlation coefficients between the weekly median normalized concentrations and the state aggregated weekly positivity rates. So they were all significantly, they were positive and significant correlation coefficients. But just wanted to note here that influenza A had the strongest correlation. So just a reminder of the 4 ways that we characterize the season, and I'll go through an example of what this looks like. So here's a figure, specifically from one of our 7 sewer sheds, Big Creek. So you can see that the start of the purple shading indicates onset, the end of the shading indicates offset in circulation, the black line indicates peak levels that were within that onset period, and then co-occurrence is any overlapping of purple shading across different targets. So here's all the data across the 7 sites for the 5 targets, and I know this is a lot to look at, and again, I'm happy to share these more detailed findings to anyone who is interested, but I've also just boiled down some of the key points. So for the 2022-23 season, we identified co-occurrence of influenza A, RSV, and SARS-CoV-2 from September to around February. And then for the next year, we identified co-occurrence of influenza A, RSV, and SARS-CoV-2 starting a little later, around October. And these 3 continue to be an onset with influenza B circulation joining around mid-December. And then in March/April 2024, influenza A, B, and RSV, and SARS-CoV-2 began to offset a little bit, and just as HMPV started to onset. And then around late March, April 2024, HMPV onset lasted around that time. Within a few sewer sheds, it was still in onset by the time of the end of data collection. So next we looked at circulation by each target across the 7 sites. So for example, we calculated correlation coefficients of influenza A levels, for example. So we compared levels among the 7 POTW sites. So we made 21 site comparisons. And we did that for each of the 5 targets. And again, I know this is a lot, and I'm happy to share more with others if you're interested in more of the details of these correlation heat maps. But just to synthesize the main findings a little bit, there were significantly positive correlations for both influenza A and influenza B across the sewer sheds, meaning influenza circulation patterns were similar across the 7 sewer sheds. For SARS-CoV-2 and RSV, majority were significantly positively correlated. However, the strength of the correlation was a bit weaker than influenza, and not all site comparisons were significant. So this might mean that these two targets are a bit more influenced by local circulation dynamics. And then HMPV had low and insignificant correlation coefficients across the watershed, meaning HMPV may be most influenced by local circulation patterns. And this was actually a similar finding to a local study that was done across San Francisco surveillance sites. So overall, wastewater surveillance has the ability to detect local circulation dynamics. So we identified the co-occurrence of several ARIs during the 2022-23 and 23-24 seasons. But it's important to note that these ARI seasons characteristics, so think about onset, peaks, offsets of these like heavy circulations, varied not only by target, but also from season to season and across different POTW sites. HMPV, for example, seemed to be very influenced by local transmission patterns, and our findings demonstrate that wastewater surveillance is a robust and complementary method for monitoring infectious disease, such as ARIs at a higher resolution than state aggregated clinical case data. So I want to thank the teams at both Emory University and within the Wolf Lab, and then of course the team at Stanford, and of course Berkeley for all the processing of samples. And most importantly, I want to thank the amazing utilities and public health partners that make this wastewater scan program work. And also, because I am also on the communications team, just a shameless plug, we have a really great, Wastewater Scan has a really great dashboard, and we also have Instagram. So here is the link for the dashboard, as well as QR codes, and then also our Instagram page where we're putting out a lot of information on how to interpret the data, and also interpreting the data on a more local level, and just providing some of the great research that we're doing as a team and as a program. So feel free to scan the QR codes as well. And here's a video of Atlanta, which is not at all representative because there's not as much traffic in this video as there usually is. I'll leave the QR codes up, but happy to take some questions. Yeah.
This is very much outside of my domain, so this may be an obvious question to others, but I'm curious in terms of the kind of intensity and the time lag between when you've taken the samples and when you get the results back, and kind of how feasible and timely is this as an a non-research monitoring tool?
The really cool part about wastewater surveillance and also the work that we're doing at Wastewater Scan is that we're able to turn around this data and provide it on our dashboard within 24 hours. And so it's really cool. I've only been working on wastewater surveillance for about a year now, and yeah, it's great. And especially compared to clinical data, there can be often a week or 2 week lag. So it's really great that we're able to get this data immediately within 24 hours.
When you're looking at cases and the coverage of where you're monitoring for the wastewater, and I guess also with how people may commute into the areas for work or anything like that, do you make any adjustments for those or any considerations when you're looking at the data?
So you mean thinking about migration patterns when people move? I think, yeah, that's a really great question. I think that's a really big question in wastewater surveillance in general. And I think also it could be the case for clinical data too. I think there's a lot of conversation going on around what can be done, but I think it's interesting to see, for example, these Atlanta sites, we're able to get these 7 sewer sheds that are across the Atlanta area. So if there is some sort of migration, I work in one of these sewer sheds, but I actually live in a different one, but I might still be captured in either one of these where I have an infection. So it's a good question, and I think there's a lot of consideration for it. I don't necessarily have an answer for that, though.
Oh, sure. So, how good of an understanding do we have of the viral shedding profiles for, the different strains of, for example, SARS-CoV-2, and how do demographic factors such as age and vaccination status affect the shedding profile?
Yeah, I know that the wastewater scan program has had a lot of different studies and analyses on the shedding. I unfortunately am not on the lab side, so I don't necessarily know the answer to that, but I know there's quite a few wastewater surveillance experts in this room, actually, if anyone is willing to take up that answer.
Sure. I think that there are a number of projects that have finished, some that have finished up recently, to characterize exactly what you're talking about related to SARS-CoV-2. I think that for a lot of our other targets, influenza A, B, any of the flu A subtypes, RSV, I think there's still a lot of unknowns, and I think that's one of the key pieces of I'm going to say basic science kind of foundational research that we need to be able to take wastewater surveillance data and be able to put it into some kind of higher level modeling side. But yeah, I think it's
No, that's one of the things that I really struggled with. I'm a wastewater-based epidemiologist myself, and there's just not enough data on it because, to begin with, I think we were looking at patients in hospitals, but are they going to be shedding more or less than people that are not in hospitals? Are people who are asymptomatic? Are they going to be shedding more or less than people that are displaying signs of infection? So I really want to see the data, basically, because I've dropped wastewater epidemiology recently. So.
Great. Thanks, everyone. One more round of applause for Hemali. We're going to move on to our next presenter, Sooyeol Susie Kim from UC Berkeley. Susie?
Great. Hi, everyone. My name is Sooyeol Kim, and I'm a postdoc at the Pickering Lab at UC Berkeley. And today I'll tell you a little bit about our efforts to reach a more integrated surveillance of wastewater monitoring by including some more pathogens and antibiotic resistance genes in the wastewater. So the benefit of going second in this talk is that I get to leverage off of all the wonderful introduction that Hemali did, and she really described how wastewater surveillance works and how well it works for viral targets. But a lot of this research has really been focused on our virus targets, and not a lot of research has been done on bacterial targets and eukaryotic targets. But having a standardized method that could extract biological material from all targets for various pathogens and antibiotic resistance genes would really enable widespread and cost-effective method of wastewater surveillance. Another aspect that's really important in wastewater surveillance is where to get the sample. So here is kind of your typical wastewater treatment plant where you have your sewage flowing into a centralized wastewater treatment plant. And one of the first things that your sewage is going to encounter is a primary clarifier, which is essentially a big bin that the wastewater can kind of sit still so that the liquid portion and the solid portion can separate and then be treated separately. And a lot of the research on the viruses have told us that viruses tend to partition to solids, and this solid sort of acts as a natural concentrator to be used in wastewater surveillance. So it would be important for other targets to also know whether they are better detected in the solids or the influent. So here are the two places that we could sample, the whole influent and the solids from the primary clarifier. So in this project, our goal was to evaluate extraction methods for a wide variety of pathogens and antibiotic resistance genes of clinical importance that you can see listed out here, and then use the extraction method that we develop here to characterize the pathogen and ARG profile of the western coast of the United States. And in doing so, we also compared the different sample types, so comparing primary settled solids with our whole influent, and also with centrifuged influent solids, where we take the whole influent, centrifuge it down to get a pellet from that influent, and then process that using our solids method. to go over a little bit of our method comparison part. So we had 3 extraction methods that we tested for both solids and liquids, where we took primary settled solids and full influent from local wastewater treatment plants, and then we spiked in inactivated pathogens that we didn't see naturally occurring in our wastewater. The 3 different methods that we compared for the solid samples were first a magnetic bead-based kit, and then the 2 other kits were silica column-based kits. For the liquid samples, we compared a direct extraction method and then a concentration method that uses affinity beads, and then coupled that with an extraction method that uses silica columns. And after that, after we have our nucleic acids, we use dPCR to quantify our concentrations and compare across all the different extraction methods. So here, I'm going to show you all the results, but I could probably take up the whole entire 12 minutes with just these results. So I'm just going to point out where the extraction kits really failed. So first, looking at the viruses, each individual point is going to be our replicate, and then the bar graph is the average of those replicates. And all 3 extraction methods worked pretty well. But when you move on to bacteria, now one of our extraction kits have failed to detect some of our bacterial targets. And then again, for our eukaryotic targets, we have crypto missing in one of our extraction kits. So based on these results and also some inhibition testing that we've conducted as well, we chose this second silica column-based kit to move on to our real-world application. Next, I'm going to show you a similar set of graphs for our influent samples, where the yellow is going to be our direct extraction kit, and then the 2 blues are going to be the affinity beads coupled with our silica column kits. So again, I'm just pointing out where the extraction methods really failed. And here, one of the affinity bead-based bead kits with the silica columns kind of failed. And then you have the bacterial and the eukaryotic targets, where 2 of our methods didn't work as well. So here we chose this method with the affinity beads along with the silica column kit to move on to our next method application. Now that we have these methods that we were happy with, we applied them to real-world samples. And we collected samples from 11 different facilities across the western coast of the United States at 3 different time points. And 8 of them were able to give us primary settled solids that were date-matched with the influent samples that they gave us. The influent sample then was separated into whole influent and then also influent that we centrifuged down to get pellets and be processed as solids. So we had 3 different sample types that we used the methods that we developed from the first part of the project and quantify it using PCR. So look at the detection rate between all the different sample types and then also compare the concentrations. So just to look at the detection rate for each sample type, we had a total of 261 measurements. So that's a combination of sample by target type. And of those 261, we had 242 measurements that agreed. So all 3 sample types said, yes, there is a detect of our target, or no, there is not a detect of our target. A subset of them were only detected by 2 or 1 of our sample types. But when you actually look at them statistically, there wasn't a difference in detection rates. A significant difference in our detection rates, which show that all 3 sample types were able to detect our targets pretty well. Next, let's look at the concentrations themselves a little more closely. So here I have the concentrations from one sample type against another sample type plotted. And the first graph that we're going to look at is on the left, going to be the centrifuge influent in copies per gram of dry weight versus the influent concentration in copies per milliliter. And each point is going to be a data point of the different targets that are colored differently. So you have the bacteria in green shades, the antibiotic resistance genes in the blue shades, the viruses in the red shades, and our eukaryotic targets in the yellow and the orange. And the different shapes are going to be the different locations that we sampled at. And you can kind of see that they form a really nice line going up with a pretty good correlation coefficient of 0.78 for our Kendall's tau. And this dashed line that you see below our points is the one-to-one line. So you can see that all our points basically lie above that one-to-one line. And this ratio is about 3 orders of magnitude. So you have 3 orders of magnitude higher concentration in the solids compared to the influent when you're looking at it in mass spaces. So we can look at a similar plot for comparing centrifuge influent solids to the primary solids, the 2 different types of solids that we used. And this time, you still see a pretty good correlation between the 2 sample types, but the line is moved a lot closer to our one-to-one line. The centrifuge influent is slightly above that one-to-one line, so showing slightly higher concentration than the primary solids, but they have a pretty good correlation and pretty similar concentration as well. And then lastly, for our third plot, you can kind of already guess what it's going to look like based on the first 2 plots, but just for completeness sake, you can compare the primary solids in copies per gram of dry weight versus the influent in copies per milliliter of wastewater, and see that it also shows up a pretty good line that's above the one-to-one line, and this ratio is also about 800 to 1,000. And this ratio is also pretty reflective of what we see in the virus research as well. So some takeaways from this research, the 3 different extraction kits that we compared, really the performance varied for all the different targets. So choosing a best kit may really depend on targets and priorities and the goals of a surveillance program. For this study, we were prioritizing being able to detect all our different targets. So that's kind of what we set our goals on and picked a kit for. Certain kits have room for optimization when targeting non-virus. So the 2 different yellow colored kits are kits that are being used pretty frequently in current wastewater surveillance systems. So if we wanted to turn those surveillance systems into ones that included bacterial or eukaryotic targets, then that means we would need to really work on the optimization of those kits that we're already using, or change out the methods so that we can really have reliable detection across all our targets. Next, the final methods that we chose for both solids and influent, we were able to detect all the targets in the real-world samples at the existing concentrations. One exception was Mpox, but that was also in really low prevalence or not detected in clinical settings when we did our sampling. And lastly, the whole influent, centrifuge influent solids, and primary settled solids showed similar detection rates and really good correlation among each other, which indicates that all sample types are viable for detecting the targets that were studied in this research. And also, centrifuge influent may be a suitable substitute when you don't have primary settled solids that are available. Sometimes wastewater treatment plants find it really difficult to sample primary settled solids, and sometimes you're working in smaller sewer sheds where you're looking at facility levels that don't necessarily have a primary clarifier. And primary clarifier solids also have an unknown residence time associated with it, so it sort of takes away that mystifying factor when you're working with centrifuged influent solids instead. And of course, all this work wasn't done by one person, as is always in science, so I would like to acknowledge my wonderful team. I would also especially like to thank Denise Garcia, who's a PhD student in our lab that really worked on the whole influent side of things. And then also thank all our wastewater treatment plant and facility staff and all our collaborators that helped us collect our samples. We are planning to publish pretty soon with a lot more details than I could fit in this 12 minutes of our 2-year work. So please be on the lookout for our preprint and our final paper. And with that, I'm happy to take any questions.
That was great, thank you. I remember, Amy, in your presentation, you mentioned inhibitors in solids, and I'm wondering how do the primary settled solids compare with influent centrifuge solids for inhibitors? Any difference there?
We didn't necessarily compare inhibition rate between settled solids and influent, but what we did see in our inhibition test of the different kits in the solids was that the magnetic bead-based kit, which didn't have any solid removal component to it, did have a lot of inhibitors in it. But our two kits the two silica column-based kits had a inhibitor removal step in them already, and those were pretty good to remove all the inhibitors. So the final kit that we chose barely had any inhibitors in there. But that is also really dependent on the wastewater sample that you're working with. So we tested two different wastewater samples for that inhibitor testing, but they had differing levels of inhibition. So it's very possible that in another wastewater treatment plant, you might have something that's really inhibiting that might not be taken care of by the kits themselves.
Really good study, very, very interesting. It seems that you found a silver bullet of way of measuring all these different pathogens. So do you reckon you'll be able to develop a kit that people could use to monitor all these key pathogens of concern?
I think you're always going to have a trade-off. So even with the kits that we were working with, we had to increase the beating time in order to really get to crypto, because that's one of the hardest targets to really lyse and be able to detect. But with increasing beating time, we lost a little bit of our virus. So we had to kind of choose a happy medium that we were okay with, saying, okay, like this is a level that we're okay with losing, but at the same time, we had this gain in crypto. So I think you're always going to have that trade-off, and no one kit is going to be able to really excel in detecting all types of targets. But I think it's definitely possible to optimize different aspects of each different kits to really fit your needs.
You had a few indicators at the beginning of the presentation. I'm assuming the BCOV was like a process control, but you had PMMOV and the 16S. Have you looked at the different indicators versus like viral and bacterial and the eukaryotic targets, and which may be better suited for those?
Yeah, so we did have some indicators where BCOV was our process control, and then we had PMMOV for an RNA control, and then CRASPH for DNA control, and 16S for our antimicrobial resistance genes. And that's kind of how we normalized Y, which I didn't present here, but the additional analysis that we did was to normalize our concentrations by those controls and then compare it that way. We haven't really looked at whether normalizing by PMMV across everything versus normalizing by another indicator, like what that effect has, but that is something that we are trying to look at. Thank you.
Yes. Great, thank you. Our final presenter of the session is Ariel Christensen from the North Carolina Department of Health and Human Services.
All right, great. Thank you all, first of all, for being here this late on a Friday. I'll try and keep the energy up so we're all awake. So I wanted to start off, and this is for those of you who are able to join us earlier for the wastewater session. This is, again, a little bit of a story. I'm into storytelling lately in public health. Applied public health world. I feel like it's very exciting when we get to do responses, and just being able to share that with folks is a good way to think about the value add that wastewater really has. So I'm going to talk a little bit today about kind of similar to some examples I was giving earlier, but this is how we were using wastewater surveillance to augment our Mpox response in North Carolina. So like this morning, I'm going to brag again a little bit on North Carolina being selected as a center of excellence for our CDC, as designated by CDC National Wastewater Surveillance System. So it was North Carolina and New York that were just awarded, and now we'll work alongside our established centers of excellence for wastewater in the country, which are Houston, California, Colorado, and Wisconsin. So really just excited to join the ranks of that group in advancing wastewater surveillance moving forward. So this story begins similar to many responses in public health, where like most outbreak investigations, we get a call on, Friday at 4 p.m., just like now. I'm surprised someone's phone isn't ringing in here today. So in September of 2023, we basically got a call that, on our Epion call, that we had identified a new case of Mpox clade 1 after 5 months of not seeing any cases in the state. So we were, of course, concerned about whether or not Mpox clade 1, I think I said Mpox clade 1, and I meant to say Mpox clade 2. We'll talk about that a little bit later. So this was an Mpox clade 2 case in North Carolina in September of 2023. So we were, of course, concerned about if we've identified one case, does that mean we have an outbreak happening here in North Carolina? So one of the first questions that we wanted to ask was, we wanted to think about unreported cases of Mpox in the state, and we were very curious if wastewater surveillance could be a tool for understanding community level transmission and being able to capture some of those potentially unreported cases in the state. As we know, there's a lot of issues with access and accessibility of testing and vaccine, and we were really curious if we could kind of pick up some of these areas using wastewater surveillance. So we implemented the non-variable orthopox assay, which was what at the time was being recommended and is still being recommended by CDC News in select, or I like to call them strategic, wastewater surveillance locations across the state. So our investigation approach really we started in October of 2023, so right after that first case was identified. And this is still actually an ongoing testing, and we are still doing this currently in a lot of our sewer sheds. So we collaborated with our university partners at UNC, who are our academic partner for Dr. Rachel Noble down at the Institute of Marine Sciences. They're our academic partner for our Center of Excellence, to stand up 10 sites as part of using that standardized assay. And that was the same assay that CDC News was using with their commercial contract for Berkeley, where we have 6 sites enrolled in North Carolina, and then it was also the same or it was a slightly different assay than wastewater scan, but was also, we also had data coming in from wastewater scan. So that was a total of 19 sites, sewer sheds that we had across the state, where we were doing once or twice per week sampling using digital droplet, PCR to look for the Mpox non-variola. The red circles are just showing you those sites across our state. So these are our total sites across North Carolina. As you can see, they're kind of clustered around some of our metropolitan areas, but we have done a lot of work to try and make sure we do have good geographic coverage across our state. But in the red circles are the areas where we are doing the Mpox testing. And again, just trying to make sure we had widespread kind of approach across our entire state to really be able to compare the timing of when we were seeing wastewater detections to the date of symptom onset for some of our cases. So our results were we've had 63 cases and 78 wastewater detections identified across the state, and they did correlate really well geographically with where we were seeing clinical cases. The majority of our wastewater detections and clinical cases occurred in more of the early February or March timeframe, which I won't show all of that timeline here. But just for awareness, that's the time when we were seeing the most cases, and things have started to taper off for Mpox clade 2 in North Carolina. One of the big things that we really wanted to do was We are a decentralized state in North Carolina, so it's really important for us to work with our local partners when we're doing this kind of testing, make sure, first of all, that they're aware that we're doing Mpox testing in wastewater, working with those local health departments, but also the wastewater treatment plants to kind of get permission and understand that we are doing this testing. And then we also make sure that we're reporting those results back to them as soon as we're getting them in. So we send these reports to our local health departments and our wastewater treatment plant partners as soon as we get our results in, which is every other week. And our wastewater detection, we also share with our communicable disease team and our leadership teams for awareness. So the green, or the yellow here shows non-detects over time. And these are wastewater treatment plants that we were sampling from. I did de-identify them. I'm just a little concerned about those things, considering Mpox clade 2 and the specific timeline we have here. So I did de-identify them, but I'll show you a map later. So the yellow shows your non-detects, the green shows what we're calling trace detects. So and the blue shows our confirmed detections. So the trace detections are really between the limit of quantification and the limit of detection for our approach that we were using. And that is really something that we coined from Wisconsin, actually. They use this terminology where you're looking at those kinds of smaller detections. It's usually 1 or 2 positive droplets using the droplet digital PCR. And then 3 or more is considered a confirmed detection in wastewater. So the blues are confirmed detections. And you'll see, we did have, as of recently, we did have a kind of clustering of some confirmed detections, which we thought was really interesting in North Carolina. And we did some targeted outreach to those local health departments to let them know about these confirmed detections that we were seeing most recently. And all of this is that ENVO assay, right? So these are suspected to be, clade 2, but then there's the question mark of, are we concerned about clade 1? And is there some specific testing that we should be doing in wastewater around clade 1, which is a whole nother conversation that we could have. But I do think it was interesting to see this because we didn't end up seeing subsequent clinical cases. And I did promise to show you all a map earlier. So although I de-identified some of those results, I did want to show you that our wastewater detections and clinical cases have been geographically aligned, mainly in our 2 metropolitan areas, Raleigh and Charlotte, where we've seen the most wastewater detections and the most clinical cases. So you can see the cases are in the, lighter green to darker green, shows the number of cases. The yellows are showing our wastewater detections. And sorry, I didn't have a little arrow there for our wastewater detections, but the yellow are our wastewater detections if the county has seen one. And I think one thing that was really interesting about this when we started looking at it was we had areas where we were seeing wastewater detections and we weren't seeing clinical cases. We were seeing areas where we saw a lot of cases and of course also seeing wastewater detections, but then we had areas where we were seeing cases and we didn't see wastewater detection. So like all 3 of those options were on the table. And I know there's a few different reasons for this, some of which has to do with the assays being used that are being discussed right now, if the ENVO is really the right approach or if we should be doing something more clade specific. To make sure that we're, understanding if it's clade 2 or clade 1. And then I think there's also the question that I was talking about at the beginning, which has to do with access, right? So some of these areas, like in Guilford County, we continue to see multiple confirmed detections and we haven't identified cases there. So I think that's a really great area for actionability when it comes to a health department, because we have evidence, right, that there is potentially Mpox circulation happening in that community, but we are not identifying anything clinically. So it gives us a little bit more impetus for some of the public health actions that we're recommending locally. And that to me is like the exciting part of wastewater surveillance is like, how are we going to use this, right? So similar to what I showed some of y'all this morning, we do have these like public health action toolkits that we're trying to develop. And again, many of these are iterative processes, and I want to hear feedback from y'all about how these could be improved. But we basically stood this up and really wanted to make sure we had this in place beforehand when we were testing for Mpox, so that we knew if we were to get a detection, what were we going to do with those results. So for here, we asked the question of if there's been a wastewater, if there's been a clinical case that's been identified around when we are seeing a confirmed wastewater detection. And we specifically chose the time range of 17 days based on the incubation period of the virus. And then we have specific notifications that we do that are already pre-established notification letters that we send to local health departments to help them contextualize and understand what Mpox, what this means if you get an Mpox detection in wastewater, because many of them don't really know. And we, of course, want to see if geographically the case aligns with the sewer shed. So we do a lot of geocoding to make sure we are understanding if we're seeing things in the same catchment area. And we also have on here considering public release, depending on what we're finding, which we haven't done yet, but is something that we continue to have in our back pocket if needed. So I wanted to also bring us back to like those confirmed detections that we were seeing recently in wastewater. We did make notifications to our local health departments who were actually pushing out additional vaccine that we had available, and but we didn't end up seeing any additional clinical cases. So I think that is a very interesting story, and a story still being written as we continue to do this kind of surveillance in North Carolina. And of course, many folks involved in all of this work, and just couldn't do this without a very massive team and our local health departments and our wastewater treatment plant partners. So thanks, everyone. Questions? Any questions? Yeah.
For the decision tree, is it pretty transferable between targets, or are there specific elements of it for every target and maybe geographical area?
Yeah, so I think we've kind of made them different for each of them. The H5 one that I showed you all earlier today was pretty specific around some of the animal inputs and using like geospatial data that we had established to understand if there's farms, if there's milk processing facilities, if there's other potential contributors coming into that sewer shed. Whereas for Mpox, we haven't gone into like that level of detail of looking at some of the geospatial data for that. And I think some of that has to do with like the population at risk that you're concerned about. Some of that has to do with like where you potentially might be, where you might be detecting the target. But I think having elements of that in all of these could certainly be expanded for the public health action decision-making trees. We were toying with the cost benefit of like how complicated to make them and like what agency partners do we need to notify to make it cohesive in the overall response versus like how actionable and usable and like quick and dirty they are, you know, because sometimes public health is, like I said, or, you know, it's the enemy, perfection is the enemy of good sometimes with the work that we're doing. We're trying to move quickly.
Thank you for another great story. So I want to ask a slightly off-topic question about sensitive diseases, and wondering, is North Carolina monitoring for polio based on what we heard in New York?
Yeah, we are not. That was an intentional decision for us here in North Carolina to not monitor for polio. I think some of these really rare conditions, wastewater has, especially with polio, has great use cases, right, for being able to do this. We are not really positioned to want to be able to do it across all of our sewer sheds. We're just looking at kind of the cost benefit of something like that. And like you pointed out, sensitivity really of that assay. We have some sewer sheds that cover 3,500 people. That's our smallest one. And our biggest one in Raleigh covers 5,500 500,000 people, so over 500,000 people. So we are, the sensitivity of some of these assays really changes depending on the wastewater treatment plant size, right? And the catchment area that you're bringing in. So we have not made the decision to do polio. I do think if the risk changes to domestically here in North Carolina, or if we have any sort of like clinical evidence that we would want to stand something like that up, we could be positioned to do so, and of course would leverage like work that was done in New York or other areas to think about that, but we have not made the choice. We've made the intentional choice not to do polio here.
It was for economic reasons.
I wouldn't say economic. I think it's also just actionability, and like if we would be able to really have it be sensitive enough to be able to pick things up consistently across all of our sewer sheds, right? Because they are the very different size. Thank you.
With the 17 days before the first wastewater detection, do you have to make changes to that timeline based on the size of the sewer shed, whether you're looking at something like 3,500 probably gets there quicker than the 500,000?
Yeah, I don't know if that would change the time necessarily. I think it's more like the concentration and the ability to detect it that it would change. So it is a consideration for all targets. It's not just for polio, that's for sure. But I think some of these targets where we would see like not many non-detects in a row, just limit our actionability, right, from a public health standpoint. And when we're worried about capacity for how much testing we can do, we want to make sure that we are able to be actionable in some of these targets that we are getting. So no, I don't think we would change the 17 days based on that. Yeah.
Any final questions? Thank you everyone for joining. We're wrapping up a few minutes early here, but the poster reception in the lobby is happening from 3:45 to 4:30. Please join us there. Yeah, we got to take the Friday Sundays.
Yes. Okay.
And we also asked them about, and they also decided not to. But
Do you feel differently? Do you have a thought there that we're not considering? 'Cause this is why we need to be here.
What work do you do? Because you
So I did my research in wastewater-based epidemiology, and one of the things that I talked about.
I didn't answer your question well enough then. Okay.
From only a few
not fair what you said, it could
So
be.
it's really nice for me to see that it can be done. It does have to trade off between this sounds silly, but because I did it during lockdown, I'm kind of still slightly traumatized from doing wastewater technology. Because it was just me and two other people.
And I think that is certainly a concern.
2+ hours a week, and it's like,
Really
I
trying
might do it again, who knows,
to change
but
interactions,
I'd like
right?
to see more wastewater-based epidemiology done on campus, because Cranfield University, which is where I'm from, we have
To like stand up
more campus and retreat for about 50% of our sewage on campus. So we've tried to make the argument that it's a model catchment, but
is,
is it?
is something that is real.
But yeah, no, it's a really interesting piece of work you did. So I'm very
Yeah.
Well, thank you for your question too.
Yeah.
Have 1,000 cases
Five miles.
of infection of the vaccine-derived.
We're the ones hosting now.
I think you're right. I was making the same argument with measles, and I don't think I know enough about polio, like Polio's a live virus.
There are two types of vaccine.
Okay.
Yeah, a live one,
I'm thinking
live attenuated one, and
I
a
keep my vaccine.
I assume
What of today?
that, sorry, because it's been a while since I've looked at this, but the strategy is the live vaccine, I think, is went down to near eradication, and then you switch to the dead vaccine. I think I could have it absolutely reversed. But it's, they use them differently depending on how much circulation, how close they are to eradication.
Yeah,
So, and I can't remember